My name is Polina Gaisinskaya, and I'll be presenting a case of idiopathic spontaneous intracerebral hemorrhage. Intracerebral hemorrhage is the second most common cause of stroke, following ischemic stroke. Particularly in the basal ganglia, uncontrolled hypertension accounts for a majority of spontaneous ICH. We present a case of spontaneous ICH in the absence of high blood pressure, as well as the absence of vascular malformation or aneurysmal cause intraoperatively. We have a 65-year-old gentleman not on anticoagulation with a past medical history of gastroesophageal reflux disease. He presented to the emergency room as a stroke alert. The patient experienced sudden onset left-sided facial droop, upper and lower extremity hemiplegia. He was fishing when a boat hit a wave, and then he fell on his behind. He suddenly experienced onset of the above focal neurologic deficits without hitting his head or losing consciousness. Patient states that he has done yearly physicals, at which time he was never told of any medical conditions, including cholesterol or blood pressure. He and his wife are fairly active, biking or walking several miles a day. The patient was brought to the emergency department where he was found to have an intraparenchymal bleed measuring 31 milliliters in the right basal ganglia. Initial intracranial hemorrhage score was 1, approximate mortality of 15%. Initial NIH performed by the neurology team was 8. Vital signs in the ED revealed a blood pressure of 143/75. Repeat CT later in the night revealed an increased size of the bleed. It was 66 milliliters at the time, ICH with a score of 1, and a repeat exam of NIH of 14. The patient was taken for emergent hematoma evacuation, and during his hospitalization, his blood pressure was within normal limits with a brief use of nicardipine post-operatively when the patient was in pain. The patient was discharged with persistent focal neurologic deficits with no improvement on dexamethasone taper, Keppra, as well as pantoprazole. Our patient's case is unique for several reasons. He sustained a fall without head injury, had no history of hypertension on routine follow-up, was normotensive aside from elevations due to pain during hospitalization, and he also had no signs of vascular malformation or aneurysms intraoperatively. His ICH was idiopathic, which is seldom reported in the literature. Typical risk factors which predispose patients to ICH were also missing, such as obesity and activity level, as the patient was an avid biker with a BMI of 22, as well as excessive alcohol intake being a risk factor, but the patient was abstinent. Interestingly, lower cholesterol and lower LDL have been found to be associated with increased ICH risk, which was found to be our only risk factor. ICH itself is difficult to foresee, let alone in the absence of risk factors or underlying predisposing conditions. Further aggressive rehabilitation following any intracranial insult remains crucial in preservation of quality of life in this patient population. And shown here in figure 1A and B is his first CT contrast on the left, which revealed a 31 milliliter bleed in the right basal ganglia, and then subsequent repeat imaging per protocol in panel B reveals an increase in hemorrhage to 61 milliliters.